Am I audible?
Yes, sir. Yes, sir. You are clearly audible and visible also, sir. Can you upload the slides, sir, so that we can check that also?
Okay.
Good evening, sir.
Okay, fine. Okay, is it visible?
Yes, sir. Slides are visible now.
Okay. So what is the plan? You have an introduction, or I start my talk?
Yes, sir. Yes, sir. We have the introduction. We will just wait for 5 minutes so that we can go live.
Should I stop sharing the screen?
Yeah. Please stop sharing your screen, sir. Now.
You have some slides?
Yes, sir.
You have some slides to be displayed?
Yes, sir. I'll just check within 5 minutes. I'll just check the technical error, means whether we are live or not, and then accordingly I'll tell you, sir.
Okay, we will start after 5 minutes. No problem.
Yes. Thank you, sir.
Hello. Yeah, doctor, we are live now.
Okay, fine. Then should I start sharing the screen? Hello? Should I start sharing the screen?
Yes, sir, you can do it. Now we are live. Let me just check with Mankind team.
Okay. So you tell me when I should start. So you can tell me when I should start.
Yes, sir. Yes, sir. Sorry for the technical error, actually. So, good evening, all of you, all my seniors, doctors. On behalf of Mankind Specialties, I would like to welcome Dr. Josh Koshy, sir. Thank you, sir, for accepting our invitations and giving your time to put enlight on newer concept and emerging indications of the NOACs. So, about the sir's introduction, Dr. Josh Koshy, sir, is the senior consultant cardiologist at the Cosmopolitan Hospital from the Trivandrum. He is the renowned cardiologist from the India and from the Trivandrum and from the Kerala. So I would like to welcome sir. And sir, you can start your presentation now.
Okay, thank you very much. I'll be speaking on the newer concepts and emerging indications of NOACs. Many people feel that NOAC is not a very proper terminology because NOAC is actually newer oral anticoagulants. It is true that they are new compared to the vitamin K antagonists, but they are not really very new. We have been using it for almost 10 years now. So a better terminology may be DOAC, direct acting oral anticoagulants. Anyway, I will be discussing some of the newer concepts and the emerging indication. We know the most important indication for NOAC is non-valvular atrial fibrillation. So let us start with atrial fibrillation. The prevalence of atrial fibrillation increases with age. The global prevalence is 1 to 2% of the general population. About 1/4 of individuals over the age of 40 will develop atrial fibrillation if they live long enough. And the prevalence of atrial fibrillation by age in people above the age of 75 years, it is 77.3% in men and 5% in women. And if you take people above the age of 85 years, it is almost 10%. The increased incidence, the important issues are one, the age, as has been shown, and increase in the risk factors like systemic hypertension, diabetes, and things like that. And third, better detection. We have better tools now available. Device detected atrial fibrillation. You know that at present, we have the Apple Watch and things like that, which can detect the irregularity of the pulse, the fast heart rate. So atrial fibrillation is increasingly recognized. Similarly, with the COVID-19 pandemic, many people are using the pulse oximeter, which can detect the fast heart rate and the irregularity. Not only that, there are many medical cams and devices, so it is detected more often. So due to multiple factors, we are dealing with an enormous population with atrial fibrillation. And majority of these people come in the category of non-valvular atrial fibrillation, and many of them qualify for treatment with oral anticoagulants. So it is important to know about NOAC or DOAC. The link between atrial fibrillation and stroke, AF, and stroke risk, 20 to 30% of ischemic strokes are associated with atrial fibrillation. So it is not a small number. Five-fold increase in patients with atrial fibrillation and stroke. Patients with AF are 5 times more likely to have a stroke than those in sinus rhythm. If you take rheumatic heart disease, mitral valve disease, 17 times higher risk of stroke compared to people who are in sinus rhythm without mitral valve disease. So very, very important risk factor for stroke. When it comes to non-valvular atrial fibrillation and the risk of stroke, we have to look at two important things. Number one, what exactly is the risk of stroke? And number two, what is the bleeding potential of this individual? So you have the thrombotic risk on one hand and the bleeding risk on the other hand. So you take these two factors into consideration and finally decide whether the individual should be treated with anticoagulant or not. We are all familiar with the CHADS2 VAS score. This is a scoring system to find out how much is the risk of thrombotic events or systemic embolism or stroke risk. And C stands for congestive heart failure, H for hypertension, age more than 75 years, diabetes, stroke, vascular disease, age between 65 and 74, and sex category. Out of this, age more than 75 years and a history of stroke or TIA is given a score of 2, others are given a score of 1. And similarly, for assessing the risk of bleed, you have the HAS blood score. Hypertension, you have 1, abnormal renal function and liver function 1 each, previous history of stroke 1 point, previous history of bleeding 1 point, labile INR 1 point, people above the age of 65, age 1 point, drugs or alcohol 1 point each. So it is important to know that. Now, all along we were using vitamin K antagonists before the availability of NOAC. Vitamin K antagonists are very powerful. They are very effective, but difficult to manage. And these are the important issues. We know about the unpredictable response. The narrow therapeutic window, you have to maintain the INR between 2 and 3, which is difficult because below 2, the risk of thrombosis, and the INR beyond 3, slowly the risk of bleeding comes. And when the INR is more than 4.5, the risk of bleeding becomes substantial. And routine coagulation monitoring is mandatory. You have to look at the INR initially too frequently, and even after that, it has to be done. And when you initiate Warfarin, it has a slow onset of action and a slow offset of action. The risk of intracranial bleeding. And the other important issue is the food and drug interaction. Numerous drugs interact. And very important, lot of inter-individual variation. The warfarin resistance, the CYP2C9, the genetic polymorphism. So there are people in whom the INR can be maintained in the therapeutic range with 2 milligram of warfarin. Some other people you require, say, more than 15 milligram of warfarin. So a little difficult to monitor because of the inter-individual variation. So warfarin and vitamin K antagonists, they are very effective, but difficult to manage. That is the point. So in this context, the NOAC or the DOAC becomes a very useful drug. And we have two groups of drugs. One is the direct thrombin inhibitor or the 2A inhibitor, that is the Dabigatran. And that acts at this level, that is the prothrombin to thrombin. 2A is thrombin. So direct thrombin inhibitor, DTI, that is Dabigatran. And you have the second group of drug, which is actually factor 10A inhibitor. They are the bands, the Apixaban, Rivaroxaban, and the Edoxaban. So these are the direct thrombin inhibitors and the factor 10A inhibitors. Now, if you ask, what is the main advantage of NOAC over the vitamin K antagonists? Apart from the dosing convenience, and you don't have to monitor the INR, no inter-individual variation, the no drug interaction in a general sense, no interaction with food. Apart from that, the main advantage is the reduction in the intracranial bleed. So compared to vitamin K antagonists, NOACs, there is a 50% reduction in the hemorrhagic stroke, and intracranial bleed. Overall, you can tell that there is a reduction in the stroke by around 19% and reduction in the major bleed by around 14%. But the GI bleed is not really reduced. In fact, some of the studies have shown some increase in the GI bleed, though it may not be there all the time. But please remember that the main advantage is reduction in the intracranial bleed. So this is a comparison of the 4 NOACs, the Dabigatran, Rivaroxaban, Apixaban, and Edoxaban. Edoxaban is not available in India. Prevention of stroke or systemic embolism. This is in comparison with Warfarin. So overall, you can tell that the combined, look at the hazard ratio, 0.81, indicating there's a 19% reduction in the stroke and systemic embolism compared to vitamin K antagonist with a significant p-value. Now, you cannot really compare the different trials because they have enrolled different types of patients with different inclusion criteria and different exclusion criteria. But look at the RELY trial with Dabigatran. The reduction in stroke is actually 34% because the hazard ratio is 0.66. So if you want an NOAC, which is more powerful than Warfarin, it is actually Dabigatran 150 milligram BID. The others are marginally better than Warfarin in preventing stroke. But overall, there is a 19% reduction in stroke compared to Warfarin. And the prevention of major bleeding in comparison with Warfarin, there again, look at the hazard ratio, it is 0.81, indicating 19% reduction. Now, what should we do for stroke prevention in atrial fibrillation? That is what is called SPAF, stroke prevention in atrial fibrillation. Compared to placebo, aspirin, there is some benefit. There is a 22% relative risk reduction. But if you compare aspirin with vitamin K antagonist, there is a 48%, there is a 38% relative risk reduction. If you take NOAC versus vitamin K antagonist, there is a further 19% relative risk reduction. So what is the conclusion? Stroke prevention in atrial fibrillation, NOACs are the best when it comes to non-valvular atrial fibrillation, even better than vitamin K antagonists. And antiplatelet therapy is not recommended for stroke prevention in atrial fibrillation. So this is the current guideline, the ESC guideline, stroke prevention in atrial fibrillation. If a patient has valvular AF, when you tell valvular AF, that means a patient with moderate to severe mitral stenosis and mechanical heart valve. They are candidates for Warfarin, vitamin K antagonist. Ordinarily, we do not give them NOAC. Now, non-valvular atrial fibrillation, what should you do? You look at the CHATS2 VAS score. If you find they have 0 score, they do not require any NOAC or any anticoagulants, no antiplatelets ordinarily. And for this purpose, the female gender is not taken into consideration. So even if it's a female, you do not give 1 point. You do not give. Now, if an individual has 2 or more points, score, again, female gender is not taken for this scoring. So if a patient has hypertension and diabetes, he gets a score of 2. A person 68-year-old man with diabetes gets a score of 2. 78-year-old lady with diabetes and hypertension. The score will be age above 75, you put 2. Hypertension, you get 1. Diabetes, you get 1. That individual has a score of 4. So certainly oral anticoagulant is indicated. Someone with a single score, 1, meaning say age 67 with nothing else. Even if that person is male or female, it does not make a difference. Oral anticoagulant you can consider, but not mandatory. Similarly, a young man, say 63-year-old man with just diabetes, the score will be 1. You can consider oral anticoagulant, but is not mandatory. And when you find the score is equal to or more than 2, certainly you should give NOAC or vitamin K antagonist, unless there is a clear-cut contraindication. If there is a clear-cut contraindication, like significant bleeding potential and all that, okay, you consider the left atrial appendage occluding device and things like that. This is again, just to tell that NOACs are contraindicated in a mechanical prosthetic valve and moderate to severe mitral stenosis. And there's one more situation, that is in a patient with bioprosthetic valve. In the initial 3 months, it is not advisable. After that, okay, you can give NOAC. Now, this is a very, very important slide which we should clearly understand. How are we treating our patients with non-valvular atrial fibrillation? Very important point. India as well as the entire world. You can look at that total, that is very important. And that blue is actually vitamin K antagonist. The other, that red shade both put together, is the oral anticoagulant. That green is the antiplatelet, and the other one is the none. In all over the world, you find the global scenario, 10% of the people are not taking any treatment in atrial fibrillation. 20% of the people are on antiplatelet. 70% are actually on oral anticoagulant. 70%, good number. Actually, half of them are on NOAC, and roughly half of them are on vitamin K antagonists. But look at the situation in India. 20% of them are not taking any treatment. And unfortunately, even now, 45% are taking antiplatelets for stroke prevention. Only 35% are on oral anticoagulant, out of which only 7% are taking NOAC. So in India, more people are taking antiplatelet than anticoagulant for stroke prevention in atrial fibrillation. So please do understand that we have to change. If you want to prevent stroke in atrial fibrillation, you have to give anticoagulant, not antiplatelet. So that is a change which we should inform everyone. It should be informed to the physician, it should be informed to the general practitioner, and every doctor should be aware of this. Stroke prevention in atrial fibrillation, it is not antiplatelet, it is anticoagulant. And out of anticoagulant, for non-valvular AF, the drug of choice is NOAC. Now we have the different NOACs available. In India, we have Dabigatran, Apixaban, and Rivaroxaban. So how do you decide? In person with recurrent stroke or TIA, despite well-tolerated vitamin K antagonists, you have to give a very powerful NOAC, that is Dabigatran, 150 milligram BID. In a patient with renal impairment, creatinine clearance is less than 30, less than 15. Then if the creatinine clearance is less than 15, then generally you don't give NOAC, you give vitamin K antagonist. But more than 15, but below, say 45, which is the best NOAC? The answer will be Apixaban or Rivaroxaban in a reduced dose. But avoid Dabigatran which is excreted through the kidney. Someone with high risk of GI bleeding, you can give apixaban. Symptoms of dyspepsia, either apixaban or rivaroxaban, not dabigatran. High risk of bleeding, you give a lower dose, either dabigatran 110 or apixaban 2.5 or rivaroxaban 15 milligram. Patient preference for once daily dosing, you give rivaroxaban. So this is a comparison of the three drugs. Now the important point is dabigatran is a poor drug, whereas rivaroxaban and apixaban are not poor drugs. Now look at the bioavailability. Rivaroxaban should always be given with food. Always remember that. We tell that Warfarin you give at 5 p.m. so that it is not given with food. Rivaroxaban, it is just the opposite. You always give it with food. Then you have 100% bioavailability. Then renal excretion, dabigatran. Whereas with apixaban, it is only 25%. Rivaroxaban, 35%. So people with renal impairment either use rivaroxaban or apixaban. And these are the trials which we know with dabigatran, it is Rely, with rivaroxaban, it is Rocket AF, with apixaban, it is Aristotle. Now, the point is, it is not a direct comparison. The population is different. Look at the CHATS2 score. With rivaroxaban, a Rocket AF trial, it is equal to or greater than 2 to 3. So patients had more risk of stroke. Now, I will touch upon the emerging concepts. That is my talk today. Now, atrial fibrillation and CAD. It's a very, very important area, overlapping patient population. Because when a patient has CAD, acute coronary syndrome, PCI, stent, CABG, in the initial 1 year, antiplatelets are extremely important. It is more important in the initial 1 month. And after that, the requirement slowly comes down. But up to 1 year, antiplatelets are important. But when it comes to atrial fibrillation, it is no longer antiplatelet, it is anticoagulant, either NOAC or vitamin K antagonist. But you find a significant overlap. You find people with atrial fibrillation who have CAD, acute coronary syndrome, or post-PCI. Now, what should you do for such people? And approximately 1/3 of AF patients have a history of CAD. And patients with both AF and CAD are at increased risk of ischemic stroke and cardiovascular mortality. So this is the real issue. Coronary stenting in patients with AF and high risk of stroke. So DAPT is important to prevent stent thrombosis. Oral anticoagulants are important to prevent stroke. And when you give both together, triple therapy, there is significant risk of major bleeding. So people try to find out what is the best strategy. What is the best strategy? So people tried NOAC versus vitamin K antagonist in combination with antiplatelets. And we have data with rivaroxaban, dabigatran, edoxaban, and apixaban. I do not have time to go into the individual trials, but I will tell the conclusion. The conclusion is that when you combine vitamin K antagonist with antiplatelets, when you combine vitamin K antagonist like warfarin with antiplatelet, the bleeding is significantly high. So when you combine anticoagulant with antiplatelet, it has to be NOAC. That is one point. Now, what should be the best strategy? I will tell one trial with rivaroxaban in which they tried 3 different strategies. That is the Pioneer AF PCI trial. More than 2,000 patients. There were 3 groups. One group received the conventional warfarin with dual antiplatelet, keeping the INR between 2 to 3. They found that the bleeding is very high in this group. The other two groups, one group received Rivaroxaban 15 milligram or 10 milligram with single antiplatelet, that is clopidogrel. The other group, DAPT, that is aspirin with clopidogrel, 75 milligram each, with Rivaroxaban 2.5 milligram BID. And after a variable period, 1 month to 6 months, you can drop one of the antiplatelets and change to aspirin with higher dose of Rivaroxaban. That is the other group. And ultimately they found the group 3 is actually the warfarin group, which has significant bleeding. The other two groups, the bleeding was less. So the conclusion is, in people with atrial fibrillation and a requirement for antiplatelet, do not use warfarin. You use a NOAC. You have two options. One, you give clopidogrel with Rivaroxaban 15 milligram. Second option will be you give dual antiplatelet, aspirin 75, clopidogrel 75 for a variable period, depending upon the thrombotic risk and the bleeding risk, for a period varying between 3 to 6 months, after which you can change over to higher dose of Rivaroxaban with aspirin alone, or higher dose of Rivaroxaban with clopidogrel alone. Now coming to another new area, thromboprophylaxis after the orthopedic surgery. So after orthopedic surgery, we used to give enoxaparin. Now this is a comparison of enoxaparin versus NOAC. This is for prophylaxis, not for treatment. People tried Dabigatran, Rivaroxaban, Apixaban. They found overall the NOACs are good. They are better. Look at the hazard ratio, 0.67, indicating there is a 33% better efficacy. And when you look at the bleeding risk, there again, the bleeding is comparable, or there is a marginal benefit for the NOAC. And something new again, the treatment of venous thromboembolism. We know that for venous thromboembolism, you can use Rivaroxaban and Apixaban straight away without giving enoxaparin. The dose of Rivaroxaban will be 15 milligram BID for 21 days, after which you can reduce it to 20 milligram daily, which can be continued. Or you can give Apixaban 10 milligram BID for 7 days, and from day 8 you can give 5 milligram BID, which can be continued. But if you are using Dabigatran, it has to be overlapped with enoxaparin for 5 days. Now, something new which has come in people with pulmonary embolism, beyond 6 months, you can reduce the dose of Rivaroxaban to 10 milligram daily. Similarly, you can reduce the dose of Apixaban to 2.5 milligram BID. And one more point, the new guideline 2019, they tell that the NOAC should be preferred over vitamin K antagonist. So this is something really new. But in people with cancer, you have to be very careful. In such people, maybe you will have to give low molecular weight heparin for longer period because of the higher prothrombotic risk. Now coming to another new area, people with acute coronary syndrome. Anticoagulation in acute coronary syndrome. Compared with aspirin alone, warfarin plus aspirin was effective in reducing the major adverse coronary events. So they do have a role in secondary prophylaxis. They reduced recurrent MI by 44%, stroke by 54%, revascularization by 20%. But why we are not using warfarin? Because of the increased risk of bleeding. And it is not very small. There is 2.5-fold increase in major bleeding. In that context, people started using the NOAC. We have some data with Apixaban and Rivaroxaban. With Apixaban, we have the APRISE 2 study. Apixaban, 5 milligram BID, was compared with placebo. This is along with antiplatelet. But the study was prematurely stopped because of the excessive bleeding. We have trial with Rivaroxaban, in which the dose of Rivaroxaban was 2.5 BID or 5 milligram BID. It was compared to placebo, 15,526 patients. The primary efficacy outcome, cardiovascular death, MI or stroke, was really reduced. Look at the p-value, 0.008. There is a reduction from 10.7 to 8.9%. And look at the other important point. There was more bleeding, but no significant increase in the rate of fatal bleeding. And if you give 2.5 milligram BID, less bleeding compared to 5 milligram BID. So at the end of that, where do we stand? Warfarin anyway is not indicated in a post-MI patient. Now, can you give NOAC? Full dose of NOAC is certainly not beneficial because of the risk of bleeding. But the vascular dose of NOAC, like Rivaroxaban 2.5 milligram BID, as was used in the ATLAS ACS 2 TIMI 51 trial, probably could be useful. Now coming to another new area, CCS, chronic coronary syndrome. We no longer use the term chronic stable angina. This is a slide we are all familiar. Now beyond 12 months, following an event, which can be an acute coronary syndrome, or it can be a PCI, or it can be a CABG, what do we find? Beyond 12 months, up to the end of 3 years, during this 24 months, there is a continuing increase in MACE. So at the end of 12 months, it is around 7%. But at the end of 36 months, it is more than 15%. So people continue to have cardiovascular mortality and MI and stroke even beyond 1 year in chronic coronary syndrome despite optimal treatment. Look at the treatment. Most of them are on aspirin, P2Y12 inhibitor, 95% on statin, 87% on beta blocker, 82% on ACE inhibitor. So we require something more for vascular protection. So that is the important point which we tell. So we target at different things. We bring down the blood pressure properly. You treat the glucose properly. You bring down the lipids with high intensity statin, ezetimibe, now PCSK9 inhibitor, evolocumab. But one area which we are not addressing is looking at the clots. Blood pressure, we are concentrating on the multiple mechanism. Glucose, you are looking at the multiple mechanism. You have the CLT2 inhibitor, GLP-1 analog. You are having the gliptin, you are having metformin, you are having insulin. Lipids, you are having multiple drugs. But when it comes to clot management, we rely only on the antiplatelet. We tell about single antiplatelet, we tell about the dual antiplatelet, but we require something more. And that is the point. Because when you look at the clot, it is not only platelet, it is fibrin. So till now, we were not discussing this fibrin. we were discussing only about the antiplatelet. At this point, people started thinking that if you give anticoagulant long-term basis, it could be beneficial. And based on the ACS ATLAS trial, we know that if you give high dose of the NOAC, there will be more of bleeding. So this is that important trial, the COMPASS trial, in which they used the vascular dose of Rivaroxaban, 2.5 milligram of aspirin, 2.5 milligram of Rivaroxaban, BID. Rivaroxaban, 2.5 milligram BID, along with single antiplatelet, that is aspirin, 100 milligram OD. They compared it with higher dose of Rivaroxaban and aspirin, because the standard treatment now for chronic coronary syndrome is single antiplatelet with aspirin alone. So they tried to find out what is better. Now the population had CAD in 91%, peripheral arterial disease in 27%. The trial had to be stopped 1 year ahead of the expectation because of the significant efficacy in the Rivaroxaban with aspirin group. So this is the patient population, people with CAD and people with the symptomatic peripheral arterial disease. And these are the inclusion criteria. I am not going into the details. And what did they find? Compared to people who are on aspirin alone, when you give aspirin with Rivaroxaban 2.5 milligram BID, there is a 24% reduction in MACE, 22% reduction in cardiovascular mortality, 14% reduction in MI, 42% reduction in stroke, and even all-cause mortality. All-cause mortality, total mortality is reduced by 18%. So first time you have a treatment which reduces mortality in chronic coronary syndrome. So this is the current antithrombotic strategies from acute to chronic atherosclerotic cardiovascular disease. So this is the event, ACS or PCI. Now in the initial 1 year, you have the DAPT. Now beyond 1 year, what do we find? We have trial in which people have used antiplatelet, DAPT, but now we have trial with the single antiplatelet and Rivaroxaban 2.5 milligram BID. But beyond 3 years, the data is with single antiplatelet and vascular dose of Rivaroxaban. So where do we stand? In 2021, this is the current guideline. It summarizes everything. Chronic coronary syndrome, beyond 1 year, what should we do? Look at the bleeding risk. If the individual has high bleeding risk, you don't consider either a second antiplatelet or NOAC. But chronic coronary syndrome at high or moderate ischemic risk and low bleeding risk, you find out whether the patient had a previous MI or not. If the individual did not have a previous MI, and if the individual has multi-vessel CAD, polyvascular involvement, multiple risk factors, along with aspirin, you can consider Rivaroxaban 2.5 milligram BID. If the previous MI was beyond 3 years, so now the patient is coming to you who had MI 5 years ago. You evaluate, yes, peripheral arterial disease, cerebrovascular disease, renal impairment, heart failure, diabetes. The drug to be used along with aspirin is 2.5 milligram BID of Rivaroxaban. If the patient is coming to you 1 to 3 years following an MI or following a PCI, if the individual tolerated DAPT, if there is a previous stroke, then you have to consider Rivaroxaban 2.5 milligram BID along with aspirin. In people who did not have a stroke, and the individual is coming to you within 1 to 3 years, then okay, you can consider DAPT in such people. In all other people, you consider Rivaroxaban 2.5 milligram BID along with aspirin. Now, before I conclude, something very new. We know that at present, NOACs are not recommended in 3 situations. One is mechanical prosthetic valve. Second is individual with moderate to severe mitral stenosis. Third is a mitral bioprosthetic valve in the initial 3 months. In mitral stenosis, we know there are a lot of thrombus inside the left atrium many times, or you find a lot of spontaneous echo contrast. But the spontaneous echo contrast and more chance for thrombus formation is there in mitral stenosis, but not in MR. The thrombus tends to be larger in MS. There is stasis of blood in the left atrium in MS. There is no stasis in mitral regurgitation. The mitral valve opens well in diastole and the LA is washed clean in systole. The LA thrombus is confined to the left atrial appendage in most of the cases of MR. But in MS, it can be anywhere inside the left atrium. So in MR, you can comfortably give NOAC. The AF in MR is actually non-valvular atrial fibrillation, especially if it is not of rheumatic etiology. Now, what about MS? Now, we tell that thrombus formation in MS and mechanical heart valve, if you want to prevent that, you have to give Warfarin. But there is a difference. Mechanical heart valve, there is greater thrombogenicity. Because the thrombogenicity is because of the artificial surface. It is not because of stasis. If the patient is in sinus rhythm, there is no stasis. It is because of the artificial surface. And multiple factors are involved. That is why we give vitamin K antagonists. And the INR recommended is at least 3. Whereas in rheumatic MS with AF, there is no artificial surface. So the issue is actually stasis, similar to what you get in, venous thrombosis. So native valve mechanism is only stasis, and the INR recommended is not 3. It is just 2 to 3. So people thought, why don't we try NOAC in mitral stenosis? Because vitamin K antagonist, we know that in majority of the people, the therapeutic INR is not there. This is one study in India. You find rheumatic mitral valve disease, the INR in majority of the patients, it is, in the subtherapeutic range. In 76% of the patients, it is less than 2. So now people have tried NOAC in mitral stenosis. This is actually a South Korean study in which they compared and they found that NOACs are okay in rheumatic mitral stenosis. In comparison to Warfarin, ischemic stroke and systemic embolism, NOACs are more effective. Intracranial hemorrhage is less with NOAC, and all-cause mortality is also less with NOAC. Look at the ischemic stroke or systemic embolism. It is 2.22% per year with NOAC, whereas it is more than 4% with Warfarin. There are similar trials also. I think, so this is an emerging concept. NOACs in patients with mitral stenosis and atrial fibrillation. We don't have a randomized clinical trial. And at this point of time, it is not recommended. Plus, please do understand that in rheumatic mitral stenosis, atrial fibrillation, at this point of time, we have to give Warfarin or acetone, but slowly NOACs are coming into the picture. And this is another area, Rivaroxaban in patients with bioprosthetic valve. We were telling that bioprosthetic valve beyond 3 months, if the individual is in atrial fibrillation, they are like non-valvular AF, you can give NOAC. But in this trial, even before 3 months, beyond 48 hours, they use Rivaroxaban. And they found that Rivaroxaban is a good option compared to Warfarin. they looked at the different primary outcome, the mean time to death, major adverse cardiac events, and major bleeding. It was favoring NOAC. Comparison to Warfarin. Cardiovascular mortality or thromboembolic events was less with NOAC. Stroke was significantly less with NOAC as expected. It was 0.6 with NOAC, 2.4 with Warfarin. 75% reduction. So in patients with AF and a bioprosthetic mitral valve, Rivaroxaban was non-inferior to Warfarin with respect to the mean time until the primary outcome of death, major cardiovascular events, or major bleeding at 12 months. The NOAC may be even better than Warfarin. But when it comes to mechanical heart valve, there's no controversy. Even in 2021, it is vitamin K antagonist, which is certainly a strong indication. But there again, we are having some rethinking. In the realigned trial, in which people compare Warfarin with Dabigatran, the trial was terminated early because of more bleeding and more thrombotic events. But the major clinical outcome occurred in the initial 3 months. Now people are trying to find out beyond 6 months or beyond 1 year with a mechanical heart valve, can you give NOAC? At this point of time, no. But again, that is an emerging concept. So door is still open. Non-vitamin K antagonist oral anticoagulation for mechanical heart valve, is the door still open? We want more trials, which are at the point of time not available. Now, following TAVR, that is the percutaneous aortic valve replacement or aortic valve implantation, we have some trials with the Rivaroxaban. I am not going into the details due to lack of time, but the conclusion is the Rivaroxaban at a dose of 10 milligram daily was associated with a higher risk of death or antithrombotic complications and higher risk of bleeding than antiplatelet strategy. So for TAVI, even now, it is antiplatelet and not anticoagulant. So let me conclude my talk. NOACs, effective and safe in MR and other valvular heart disease with atrial fibrillation. So when you tell non-valvular AF, please understand it is moderate to severe mitral stenosis, not aortic valve disease, not MR, especially non-rheumatic etiology, in which you can use NOAC. NOACs are safe in mitral bioprosthetic valve with AF beyond 3 months, maybe even earlier beyond 48 hours. But mechanical heart valve do require Warfarin or vitamin K antagonist. Now, newer data now suggests that NOACs are more effective than vitamin K antagonists in mitral stenosis with AF with lesser bleed. But we want more data. A randomized trial is required before NOACs are recommended as standard of care in moderate to severe mitral stenosis. Now, we should prefer NOAC over vitamin K antagonist in non-valvular atrial fibrillation. Now, NOACs are increasingly used in VTE, venous thromboembolism, and pulmonary embolism and anaphylaxis. And we can tell that NOACs have to be preferred over vitamin K antagonists in venous thromboembolism as per the current guidelines. NOACs are preferred over vitamin K antagonists along with antiplatelets in chronic coronary syndrome. Proven role in acute coronary syndrome. The post-PCI patient, that is what is mentioned, NOACs are preferred over Warfarin along with antiplatelets. So Rivaroxaban with a single antiplatelet or Apixaban with a single antiplatelet has to be preferred over a vitamin K antagonist with antiplatelet. And finally, very, very important, based on the COMPASS trial, chronic coronary syndrome, the entire concept is changing. Beyond 1 year, if you think the patient has high thrombotic risk, less bleeding risk, it is not dual antiplatelet drug. It is DPI. What is DPI? DPI is dual pathway inhibition. What does it mean? 100 milligram of aspirin or 75 milligram of aspirin with 2.5 milligram BID of Rivaroxaban. And that is the way forward. Thank you very much. And I would like to express my gratitude to Mankind Pharma for this kind invitation and for the initiative. Thank you very much.
Thank you, sir. Thank you for giving such a wonderful insights. We have some couple of questions actually, sir. I'll just read for the benefits of others. So question first is asking from Dr. Sharad Sathe from Aurangabad. He's asking, Doctor, according to you, what is the best strategy for atrial fibrillation in PCI patients?
Best strategy for PCI, post-PCI patients. See, initially you have to give dual antiplatelets. There's no doubt about that. If it is not an LM or a proximal LAD or long stent or multiple stents or anything like that, then you assess the bleeding potential and the thrombotic risk. If the bleeding risk is not too high, thrombotic risk is high, you can give the DAPT for a period of 3 months. But if the bleeding risk is more, if the thrombotic risk is comparatively low, and newer generation stent, well deployed, especially if you have used imaging, non-LMCA location, you are very comfortable. You can cut short the DAPT to 1 month. And along with that, you have to give an anticoagulant for atrial fibrillation. Certainly the anticoagulant should not be vitamin K antagonist. It should be a NOAC. We have data with all the NOAC, but Rivaroxaban in a reduced dose will be a good option. And when you stop the second antiplatelet, then you can continue with Rivaroxaban 15 milligram with clopidogrel 75 milligram. Because combination of Rivaroxaban with clopidogrel probably produce slightly less bleed compared to combination of Rivaroxaban with aspirin. Now, during the initial 1 month, what dose of Rivaroxaban should be given? Okay, there may not be a consensus on that, but certainly not a high dose. 15 milligram will be reasonable, along with 75 milligram aspirin and 75 milligram of clopidogrel. Even 10 milligram will be reasonable, but 2.5 milligram BID is not adequate for stroke prevention in AF. 2.5 milligram BID is actually for vascular protection in chronic coronary syndrome. And instead of Rivaroxaban, you can also use Apixaban. You have data with Edixaban as well as with Dabigatran. But the concept is the same. Triple therapy for the minimum period, varying between 1 month and 3 months. And beyond with single antiplatelet with NOAC. Then you can give higher dose of NOAC. But when you are in the triple therapy, use lesser dose of NOAC. Now, finer tuning depends on the bleeding risk and the thrombotic risk and the type of PCI performed and taking multiple factors into consideration. Anyway, no longer triple therapy with Warfarin. I think it is clear.
Yes, sir. Thank you, sir. One more question is there. Dr. Arshad from Pune is asking, is there any role of NOACs in COVID-19? And if yes, which NOACs at what dose?
No, we do have some recommendation. Now, you know, the prothrombotic state is very important in COVID. Now, usually the issues, the thrombosis, both pulmonary as well as coronary all along, because, you know, there is endothelial inflammation, there is prothrombotic state, MI, stroke, everything. Usually it happened by the end of the 1 week. The point when, you know, slowly you find the COVID test becomes negative. You do the rapid antigen test, you find it is negative, the patient is very happy. Then all on a sudden, you know, you find the patient developing pulmonary embolism or acute coronary syndrome or stroke or something like that. So that is the time frame when usually people develop a thrombotic complication. So the current recommendation, moderate to severe COVID, they can be given enoxaparin during the hospital stay, and at the time of discharge, they can be given either Dabigatran or Rivaroxaban or apixaban. The recommendation is for either Rivaroxaban or apixaban. Rivaroxaban 15 milligram can be continued, and some study has come recently which tell that if you give the anticoagulant prior to the admission in a COVID-19 patient, especially those patients in whom the D-dimer is significantly elevated, it can be more effective in preventing thrombotic complication. Anyway, in conclusion, mild COVID, normal D-dimer anticoagulants may not be required. Moderate and severe COVID, anticoagulants are recommended, especially with severe COVID, enoxaparin, depending upon the body weight, during the hospital admission. If there is renal impairment, then you may have to go for unfractionated heparin. The other option is at the time of discharge, NOAC. Good option will be NOAC, Rivaroxaban 15 milligram, or apixaban 5 milligram BID. Moderate COVID, less thrombotic risk, less the level of D-dimer, 2.5 milligram BID of apixaban, or even lesser dose of Rivaroxaban could be okay. But people with normal D-dimer, mild COVID, anticoagulants are not recommended. Now, how long should you give that? Again, there is no clear-cut consensus, but 6 to 8 weeks will be reasonable. But we should remember that the bleeding risk of NOAC is around 2% per year, which ordinarily may not be too high. So people with high Has blood score, you have to be very careful when you use that. So anticoagulants are certainly indicated, but you have to individualize.
Yes. Sir, there is one more question actually from Dr. Srinivas, Hyderabad. Doctor, is there any INR monitoring required for NOACs also?
Actually, there is no requirement for monitoring the INR. That, in fact, is one advantage of NOAC. But if you monitor the INR, you may find the INR is prolonged. I have found people on Rivaroxaban with INR 3, 3.5 and all that, but you need not check that. And if at all you find an abnormal value, it can be ignored. You need not take that into consideration in deciding the treatment. But please do understand that the NOAC can also prolong the INR, but that is not useful for monitoring, nor is it recommended.
Okay, sir. Sir, again, this Dr. Arshad from Pune, he's asking, should we give low dose of Rivaroxaban in symptomatic patient who is having the high D-dimer?
Symptomatic patient. See, when you tell about symptomatic patient with elevated D-dimer, certainly it is at least moderate COVID. It is moderate to severe COVID, symptomatic patient with elevated D-dimer. The recommendation is to give anticoagulants. Enoxaparin if the renal function is okay, unfractionated heparin if you find creatinine is high, and at the time of discharge, either Rivaroxaban or apixaban.
Yeah. Yes. So thank you, sir. There are a lot of people actually who are online right now, and I think so our time is already over. It's already 9:10. So, sir, from on behalf of Mankind Specialties, again, I would like to thank you very much for sharing such a wonderful, different insights on the NOACs. Sir, one wonderful things which we like it, the Garfield Registry Insights, which shows that in India, more doctors, they are using the antiplatelets is being used for the treatment of newly diagnosed atrial fibrillation rather than the NOACs. And I'm sure after these sessions, all delegates who are attending these sessions, they will pass on the benefits of NOACs to all atrial fibrillation PCI patients or secondary prevention of CAD patients or the stroke prevention in atrial fibrillation patients, and also for the treatment and prevention of DVT and PE patients, sir. So thank you so much for sharing such a wonderful insight, sir, once again.
Thank you very much. I think that is the message.
Yes, sir.
In atrial fibrillation, it is anticoagulant and not antiplatelet.
Antiplatelets. Yes, sir.
Important message. And try to prefer NOAC over Warfarin.
Yes. Thank you, sir. Thank you.
Thank you very much.
Good day, sir. Yeah.